Hello, and welcome to members of the Utah Physicians Quality Care ACO. My name is Adam Kirking. I'm a Director of Operations for Imperium Health. Today we are going to discuss two continuity of care visits that we believe are core to successful ACOs. We will introduce annual wellness visits and transitional care management visits and review the steps for establishing successful AWV and TCM programs. Today is our first webinar with UPQC. Our webinar series will provide insights that will help your practice to be successful in a Medicare Shared Savings ACO. These sessions will range from post-acute care management to quality improvement. Today we're going to go over a couple nuggets for those really busy providers that we want to make sure that they get a couple takeaways that they can take with to help establishing the programs. And then we're going to review the annual wellness visit and transitional care management programs and the steps necessary for implementing sustainable programs. We'll provide and discuss a couple of the supporting resources that will be available to you. And then we'll discuss the next steps and the things that we want to make sure that you are doing on your own to be successful for these two programs. Imperium Health is an ACO enablement company, and one of the biggest strengths of Imperium is our belief in shared learnings and sharing the best practices for our members in ways that allow you to take a workflow and kind of bend or adapt it to best fit the needs of your organization. The Imperium Health building blocks, which you can see here, reflect those beliefs and shared learnings and will tie into our webinar series that we will be offering to you. The ACO is measured on performance as an organization, and we will do our best to make sure that not only are the more advanced practices getting exactly what they need, but those that are just starting their ACO journey get the support and the attention that they need to be able to be very successful in not only improving the health of your patients, but performance within the Medicare Shared Savings ACO. So the two visits that we're going to discuss today are the annual wellness visit and the transitional care management visit. They're two very different visits, but both are very important for overall ACO performance. And the annual wellness visit is beneficial because it can be really good extra revenue to your practice. But at the same time that you're doing that, it's an opportunity to identify and close gaps in care, identify your really high-risk patients and those ones that maybe need a little bit of extra attention. You're going to increase your attribution because you're going to be seeing more patients for these well visits. And then you're going to increase your patient satisfaction because more patients are going to be going and looking to you as the person that helps them to stay well and not just helps them when they're sick. And this is a little bit different than that transitional care management visit, which is, maybe similar to how we would think of that post-hospitalization clinic visit, but it's going to be kind of an enhanced version of that. And we found them to be very successful in helping to avoid readmissions, also helping to increase your attribution. And it does close that medication reconciliation post-hospitalization ACO quality measure, which is one of those Medicare Shared Savings ACO measures. And then you're going to increase your patient satisfaction and patient engagement. Again, also because those patients are going to start to think of you and go to you as the resource for when I'm not feeling well, when I'm starting to maybe just start to feel a little bit better. They're going to really view you as the quarterback and the person that they're going to for all of their care. Now, an annual wellness visit is unique in that it's not a physical. It's not a head-to-toe digging deep into every component of the patient's health. But what it is it's an opportunity to gather a lot of information about our patients. And it does not need to be done by the provider alone. I would really view an annual wellness visit as a team visit. And if you are not at a federally qualified health center or rural health clinic, this is actually a visit that can be done by a clinical team member under direct supervision of a physician. Now, we don't typically promote that quite as much, but I like to bring that up just in context of this does not need to be a full provider visit. This is a team visit where you're going to involve as many members as possible from your organization. And again, every practice is a little bit different, so how you are going to implement your annual wellness visit program could be a little bit different than the practice that's just up the street from you. It's an opportunity to develop a care plan or actually close 14 of the 15 ACO quality measures. And you're going to improve your ACO attribution because you're going to be seeing more of these patients when they're well. And then you're going to be able to document for underlying chronic conditions, or maybe ones that you had not documented for in the past, but are kind of known, but you just hadn't documented on them. And because it is such a structured visit, we believe in using templates as much as possible, because this is a visit that You know, the less variation from patient to patient that we can have as part of this, the more likely we are to be able to capture information consistently. And I'm a big fan of, if we can capture information the right way the first time and be able to use it in multiple different scenarios, that's awesome for everyone. The TCM visit is, again, it's similar to that, maybe when you would see a patient when they leave the hospital, but it's going to involve an interactive portion before the patient actually gets into the practice. And that's called an interactive contact. And that's a call within 2 business days, so not necessarily calendar days, 2 business days of seeing that patient or of contacting the patient by phone, maybe by email, maybe by some sort of a web portal to check in on them, make sure that they're doing okay, and answer any questions. And then you're going to do a face-to-face visit within 7 or 14 days with a provider. So that interactive phone call, that does not need to be with a provider. That's usually with an MA or with some other clinical team member. But the face-to-face visit, that is actually with a provider. The benefits of doing transitional care management visits, it reimburses really well. This is one of the highest paid codes for a clinic visit, and they have been shown to reduce readmissions. And then for both of those visits, one of the things that is important and I know is important for your organization is your opportunity to capture more revenue. And the annual wellness visit is one of the kind of real gems for capturing information while at the same time starting to do that transition to a fee-for-value type care arrangement. And an annual wellness visit is an opportunity to maybe perform that advanced care planning, that end-of-life discussion with your patients. And then that transitional care management visit is, again, one of the highest paid codes for a clinic visit, and really has been successful in helping to reduce and avoid potential readmissions. So I view the annual wellness visit as really an information gathering visit, and it's not necessarily a true physical. What it is it's a chance to do your health risk assessment, and many of your practices are probably doing something similar to a health risk assessment today, where you're getting a lot of that background information about your patients, but this is going to go a little bit further than that. You're going to review the current providers and the current medications that the patients are taking, or that the patients are seeing, or that the patients are taking. And I think that's so important, because too often within a Medicare Shared Savings ACO, we have discussions with the providers about, I didn't make that referral, or I didn't know that was happening. Well, an annual wellness visit is a chance to gather that information and start to learn who our patients are seeing when they're not in front of us. It's a chance to review risk factors such as depression or smoking. Start to think about, okay, how can we maybe control your hypertension? How can we control your obesity? This is a chance to come up with that personalized prevention plan for the patient. So although it's not that head-to-toe physical where you're doing labs and looking at x-rays, it's a chance to think about, how can we make sure that you get your mammogram, get your colonoscopy, get your depression under control. Start to think about, how can we manage your diabetes a little bit differently. Ensure that you're getting your diabetic eye exam. This is a chance to think about, how can we care for the patient in that more holistic way. And to be successful with an annual wellness visit, and then to turn that visit into a program or something you can adapt for all of your patients, I think it takes about 5 steps to do well. Today we're going to just discuss the first 3, and we're going to get into all 5 of these a little bit later over the course of the year. And again, anything that has a wrench down at the bottom, those are things that we're going to have extra tips or extra support resources available to you. Many of the things that have the wrench are included in the annual wellness visit or transitional care management toolkits, and those will be provided to you. So to be successful and sustain an annual wellness visit program, again, I think it's those 5 key steps. And one of the first is to make sure that your medical record, whether it's an EMR or an EHR or a paper medical record, is as effective as it can be. And again, I'm a big fan of, if you can capture something once and have it be used to not only capture a quality, satisfy the visit requirement, but also, can we use it to close a gap in care? Can we use it maybe to improve the risk coding for our patients? Anything that we can do related to that, where we're capturing information in a really effective way, is so important. We're going to need to make sure that the team members, whether it's a registration team member or a physician, understands the value and the purpose of the visit. Because if you don't, then it's hard to explain to the patient of, why am I not here for a true physical? What do you mean we're not going to do labs? Well, we're actually here to gather information about you, because we're going to develop a care plan to make sure that over the course of the next year, we're able to meet all of your needs. we're going to need to make sure that our billing is correct. Too often I've had discussions with providers where they felt like, I've done 80% of my visits. There's no way that I should be listed at 50%. And then it turns into a delay in claims type discussion when unfortunately it was actually that maybe their biller was billing a G0402 as a 99214. And essentially what that means is every time that biller did that incorrectly, it cost the practice about $65. So we want to make sure that you're billing everything correctly. And we're going to go over a couple of the little tricks for making sure that you can optimize your annual wellness visit program. In our next round of education series about annual wellness visits, and there is some information in that toolkit, is starting to think about how can we proactively schedule our patients for annual wellness visits. And then we're going to need to make sure that we're monitoring our program to make sure that we're hitting those goals and hitting those targets for ourselves. Oftentimes I would say that 80% is a great goal for an ACO. If you can hit 80% of your annual wellness visits, you're likely to reduce that quarter-over-quarter variation of your Medicare shared savings patients, as well as it's going to really help your revenue overall. And I touched on it a little bit ago about capturing information, and that EHR template is such a big component of capturing information. And I would typically think about the information that we're going to capture as maybe two different buckets. And again, a lot of these can be clinic by clinic or EHR by EHR dependent, because even though it might be eClinicalWorks or even though it might be Cerner, the version that you have could be slightly different than a practice across town, and the way you're using the EMR could be slightly different than someone else across town. So one of the things that we want to make sure that we're doing within our EMR template is we are the things that are on the left side, those are things that maybe we want to try and capture through some billing things. That a fall risk assessment might not be entered into a discrete data field, or a review of a breast cancer screening might not be entered into a discrete data field, but it's something that we can bill for. Reviewing that a patient has had an influenza vaccination, that's great. But if we can document or do some sort of additional billing, that can help us to make sure that we're closing those gaps in care real time. And the things that are in that kind of bluish box, that's information that can usually be captured through some sort of a report, whether it's a BMI that becomes automatically calculated, a blood pressure measurement where you can pull that discrete systolic and diastolic measurement, or pull a patient's immunization or medication history. Those are things that we can oftentimes pull because they're entered into discrete fields. Now, if anything on that left side is entered into a discrete field within your EMR, awesome. That's going to make it a little bit easier to pull the information. For those of you that are using a paper practice, we may encourage you to do a little bit extra billing to try and make sure that we're using the CPT2 codes and the G codes to capture all of that information. But the more we can try and capture information as part of the visit, the easier it's going to be over the course of the year. And then when it gets audit time the next year, the easier it will be to find the information and validate it very quickly. And then, I mentioned just a second ago about having everyone within the organization being informed about what the visit is. And I think even more important than that, it becomes informed about what their role is within the overall structure. And this is set up to have six distinct people, or 6 distinct positions. And I know in many of your organizations, this is somebody that's going to be merged together. It might be 3 people, it might be 2 people, it might be 12 people that are making up these different responsibilities. But I think they're all important, and it helps us to kind of bifurcate our mind of how are we separating out who should be taking care of which responsibilities. And I'm a big fan of, if no one is responsible for it, sometimes it doesn't get done. And that registration team member, one of their biggest roles is going to be, when the patient comes in, giving them the health risk assessment to make sure that they're filling it out. And then converting those follow-up visits. Maybe a patient's coming back for a 6-month follow-up on something that they just come in every 6 months for. Can we get them converted to an annual wellness visit? And that could be doing a follow-up visit or a sick visit in addition to an annual wellness visit. And if you're doing that, you're using a modifier 25. Or it could be, let's take this patient that's coming in and, we don't necessarily need to follow up on their depression today or their hypertension today, but we could do an annual wellness visit if the patient is okay with that. And by doing that, the patient is able to be seen for the annual wellness visit, and the patient doesn't have a copayment, which is great as well. The biller and the coder, I touched on a little bit earlier about making sure that the billing is being done correctly, because the difference between a G0402 and a 99213 or 214 could be $60 or $70 per visit. We need to make sure that you're capturing those correctly every time. We need to make sure that you're auditing your claims to make sure that not only are you billing for it correctly, but the claims warehouse is accepting it, and that the claims warehouse is then making sure that everything gets paid. Because if we're doing a visit and we're doing kind of a change, we want to make sure that we're monitoring our progress, and ensuring that the billing is being done correctly is one of the best ways that we can monitor our overall performance. The clinical team members, your responsibilities could be as great as doing almost the entire visit on your own, or doing the entire visit on your own, or it could be making sure that you're identifying those risks within the health risk assessment, coaching the patient on maybe the mini mental exam, or coaching the patient on a fall risk assessment. And when I say coaching, I mean going through the process with the patient and then helping to start come up with an action plan, because those are going to be things that the provider is going to be doing the action plan for, but having you there to support it and get the process going makes such a difference. Growing the program from 20, 30, 40% of your Medicare eligible patients to taking it to 60 to 80 to 90% of your patients relies on the scheduler. And that scheduler needs to be proactive. And I think about the scheduling component as everything from when a patient leaves an annual wellness visit to get them scheduled to the next year's annual wellness visit. That's somebody that's kind of in the rotation, to somebody that's maybe never had one, or somebody that's newly eligible for Medicare. How can we make sure that we're mining our schedules to identify those patients that are newly eligible for Medicare, and in the first 12 months of their Medicare Part B eligibility, to get them signed up for that IPPE, or the Welcome to Medicare visit? The provider, the most important, you're responsible for overseeing the quality of the program. But then on a patient-by-patient level, you're responsible for reviewing the information and developing that personalized care plan for each patient. And the administrator and that team lead, you're responsible for making sure that everything goes as smoothly as possible. And that may mean helping to make sure that the EMR is set up to be as effective as possible, making sure that your biller is billing things correctly. It may mean that you're working with the schedulers to ensure that we're scheduling in a way that makes the most sense. And I say that in terms of, maybe we want to do an annual wellness visit day, and every Tuesday or every Thursday we're going to schedule 10 or 8 annual wellness visits. Maybe we want to schedule our annual wellness visits to be no more than 1 an hour, or no more than 2 kind of a day or a shift. You might do a sick visit, a well visit, a follow-up visit, an annual wellness visit. And if you can kind of balance those out and schedule those out, it can make a difference in getting your patients through and getting them seen a little bit easier. And then billing for the annual wellness visits makes such a difference. And I would say that the successful organizations with their programs are the ones that have really been able to sustain success. Use all 3 of these codes. Now, I want to make sure that I bring up, with an annual wellness visit, and this is a once every 366 days visit, as opposed to a once every calendar year visit. Now, that's different than a Medicare Advantage physical, which is oftentimes a once a calendar year, or maybe a well woman exam, which is a often once a calendar year visit. A annual wellness visit is a once every 366 days visit. And I've talked to practices that have said that they build it on the 12th month and they've been fine, and I've talked to practices that have said they built it on the 365th day and had the claim be denied. So kind of with those 2 examples, I would always encourage you to say do the 366th day. So for that scheduling example that I mentioned a little bit earlier of patients coming out of the annual wellness visit, let's get them scheduled for the next one. If today is January 15th, let's get them scheduled for January 16th, assuming that that's a weekday and that the clinic is open, and it works for the patient. All 3 of these visits are 100% paid for by Medicare. Now, with these visits, there might be times when you're having a patient coming in for maybe a sore throat, and you want to do an annual wellness visit, but they also have this other issue going on. If you're seeing a patient in a traditional fee-for-service clinic, so not an FQHC and not a rural health clinic, you can bill for an annual wellness visit and a sick visit at the same time if you're using a 25 modifier, or a modifier 25. Now with that, the sick visit, so if it's a 99213 that you're doing in addition to the annual wellness visit, that sick visit, that will probably have a copayment associated with it, depending on the patient's insurance plan or if they have some other supplemental plans. But if you're doing a annual wellness visit and maybe you have that end of life discussion, that advanced care planning discussion with the patient, if you do a modifier 33 with that, now you can have an annual wellness visit and also have that end of life discussion with the patient. So that's two really great, really important ACO visits that you're able to get done, and there's no copayment to the patient for either one of those. If you're ordering labs or ordering imaging as part of an annual wellness visit, the patient will probably have a copayment for those visits. And those are things that are not covered or not necessarily associated with a true annual wellness visit. If you're a FQHC, that federally qualified health center, you're going to bill as a G0468 for all 3 visits. If you're a rural health clinic, you're going to bill as the G0402, G0438, and the G0439, just like a traditional fee-for-service clinic. And those are going to be paid at your all-inclusive rate. If you are a rural health clinic seeing a patient for a sick visit at the same time as a welcome to Medicare, and that's that first 12 months of Medicare Part B eligibility, you can bill for both visits, and it'd be treated almost like if you're billing for a behavioral health visit at the same time as a wellness visit, or behavioral health visit at the same time as a medical visit. There's more information about billing and coding in the toolkit, and there's more information that we will probably be bringing up to you along the way. If you have questions about billing and coding, please ask. That being said, now we're going to transition into those transitional care management visits. And this is, I like to think about it as kind of a really souped up version of a post-hospitalization visit. And we know that the transitional care management visit has been one of the most successful ways for achieving overall ACO success. Not only because you're able to achieve savings by reducing those readmissions, but you're able to improve your quality by capturing that medication reconciliation post-discharge, but you're also really able to improve your patient engagement because your patients then have a better understanding of, my primary care provider, they care about me. They want to make sure that when I'm discharged from the hospital, even if it's not in the same town, that they need to know about it, and they want to make sure that they're helping me to be successful and to thrive when I leave. A transitional care management transitional care management visit can be performed after a patient leaves a traditional inpatient setting, so that's maybe like an Intermountain Hospital, maybe a St. Mark's, or leaves a long-term acute care hospital, leaves an inpatient rehab unit, leaves a skilled nursing unit, and that's a skilled care, so they're probably getting that therapy as opposed to a nursing home where it's kind of like that becomes their permanent residence, or an observation stay. And you're going to do a TCM visit, or you could do a TCM visit when a patient leaves one of those 5 settings and goes home. So that's going to be your cue to make sure that when a patient is going home, that we're seeing that patient right away. And the reason why we want to see that patient right away is we want to ensure that they're going to thrive when they go home. Now this graph on the right looked at Imperium discharges from 2016 and 2017, and what was the impact of doing that TCM visit or seeing the patient within the practice within either 30 days for that PCP visit or within 7 or 14 days for that TCM visit. And we can see on this graph what a huge difference it makes. Another study that we didn't put on here was looked at what was the most likely date for a patient to be discharged back to the hospital or be readmitted back to the hospital after a discharge. And a patient was most likely to be readmitted back to the hospital on days 1 through 4, which really ties into that TCM visit of doing that interactive phone call, reaching out to the patient to ensure that they're doing okay, that they're thriving at home, that they have what they need, and that we're bringing the patient back in the clinic as soon as possible to just ensure that they're getting exactly what they need. And similar to an annual wellness visit, I would say that a TCM program, to be really successful, you're going to probably want to think about it in these 5 steps or almost these 5 buckets. Now you can do a TCM program without trying to master all 5 of these, but I would say that to really sustain it and have it turn into a program as opposed to a couple one-off visits, you're going to want to try and do all 5 of these just about every time. And the first, and honestly can be one of the hardest, is to make sure that we're getting our discharge notifications, not only from that acute setting like a hospital, but from those post-acute settings, like maybe a patient gets discharged from Health South, maybe a patient gets discharged from a nursing home. How can we make sure that not a nursing home, a skilled nursing unit. How can we make sure that we're bringing that patient into the clinic, and how do we make sure that we're aware of it? Once we're aware of it, we can do that phone call. We can start to think about how can we have a clinical team member make that phone call to the patient within 2 business days. We can think about how can we have our scheduler ensure that we're having the patient come in within 7 or 14 calendar days. We can conceptualize all of these once we get that discharge planning done. And a great thing about the UPQC ACO is that through the UHEN, you have better access to discharge notifications than most ACOs and most practices across the country. So I'm very excited about not only the work that Lori's able to do to help you, but what a great tool and what a great service that is overall. After we see the patient in the practice, similar to the annual wellness visit, we need to make sure we're billing for it correctly. Again, I've had, unfortunately, too many horror stories of practices that are seeing the patient within 5-6 days, think they should be billing for a $230 visit. The biller doesn't understand the code and bills it as a 99214. Maybe even bills it as a 99215, because if it's that 7-day visit, it's probably comparable from a medical complexity standpoint to a 99215, but the pay difference is not close, or from an RVU perspective is not really close. But we need to make sure that the team members are educated about what this visit is and how important it is. So I talked about the discharge notifications quite a bit, and I believe that the discharge notifications are really the linchpin to a successful TCM program. Now, there's 4 ways from my experience in which you can be notified about a patient leaving the hospital. And they're arranged on here kind of from most complex to least complex. And again, we have a little bit more information about this in that TCM toolkit. The kind of most basic and rudimentary is the patient notifies the practice directly. And that could be, if I'm Adam and I'm leaving the hospital, that I know that I need to call my doctor within the first day or 2 to make sure that I'm letting them know that I'm discharged from the hospital. And I've seen this to the point where you might even have a patient that gets discharged from the hospital and is calling the practice on their drive home. Now, if we're having our patients starting to contact us directly, let's make sure that we're asking good questions, because there are a lot of hospitals in the country and there's a lot of hospitals in Utah. So if we have a patient that says, "Hi, Dr. Brown, I was just discharged from the hospital in Salt Lake City." Okay, great. Which one? Because if we don't have that next level of information, it can be hard to really connect those dots to the patient. The next way we can get access or find out about those discharge notifications is sometimes a clinic will have access to the hospital EMR, and they'll go in every day or every couple days to just check to see which patients have been discharged. Sometimes the hospital or the post-acute facility will notify the practice directly, and I would say that this is usually kind of a preference if we can get to this point, and I know in some of our practices we're getting this today. And I know from past experience in a job that I had before this where I thought my organization was sending discharge notifications to a practice. Turns out we were sending them to the wrong fax number, and turns out we were sending them in another instance to the right fax within the organization, but maybe the wrong fax machine. So we were sending it to a fax in medical records when we needed it to go to more of the clinical pod where somebody was going to be able to do something with the information, as opposed to scanning it and putting it into the medical record. And then through the UHEN, we have access to the health exchange, and this is such a neat tool where we're able to get those discharge notifications almost real time in a really organized way, and I think that's such an advantage that we have for UPQC. The interactive contact, I think, is really, really doable once we find out about it. And again, the interactive contact is an interaction between a clinical team member and a patient or a patient's family within 2 business days of discharge. So if it's Monday afternoon and a patient's discharged, that means that we have Monday would mean we have Tuesday and Wednesday to reach the patient. If the patient's discharged on a Thursday, we have Friday and then Monday to reach the patient. The patient's discharged on a Friday or a Saturday, we have Monday and Tuesday to reach the patient, or Friday, Saturday, or a Sunday, we have Monday and Tuesday, those 2 business days following the discharge. And now these are not necessarily the only people that can be doing this visit, but a couple of the common examples that I've came across of clinical team members that would be reaching out to the patients. It can be the provider, but I'd like to really point out it does not need to be the physician. It does not need to be a nurse practitioner contacting the patient, although it can be if that's your preference. Oftentimes it's a nurse, an LPN, could be a pharmacist, could be a pharmacy tech, could be a social worker, and it could be a certified medical assistant. And the call is meant to answer some clinical questions if the patient has them. You can do a medication reconciliation, although you do not have to do the med rec over the phone. It's more of a, let's get you scheduled, but what questions do you maybe have at this time? Were you able to get your meds? If you were supposed to be on home health, has the home health nurse came yet? And very importantly, we need to make sure that we're documenting this call. Usually a gold standard is if you are able to do it within your medical record as a phone interaction or a telephone encounter, that's great. That's usually the easiest to pull forward into a transitional care management visit, so pull that note forward. But if it's just documented in a notebook, that's fine. We just need to make sure that we have access to the notebook. And the TCM program roles and responsibilities, again, I think this, knowing where everyone needs to sit on the bus to be successful, whether it's that annual wellness visit, TCM program, or when we get a little bit later in the year and start talking about other services and other ways of coordinating care for our patients, defining the roles and putting people on the right seats on the bus makes such a difference. For the clinical team member, they're going to be performing that 2 business day phone call. They're going to be probably working with the patient to make sure that the visit gets scheduled. And they're going to be educating the patient on, you need to come in, we need to see you. I don't want to say that the patient might feel like they don't need to come in, but anything we can do to really encourage the patient that they need to come into the practice, we need to see them make such a difference, because there might be something that the patient feels like is going pretty well, that when we as a clinical team have a chance to kind of lay eyes on them and work with them, we know that they're maybe not doing as well as we first thought. The provider is responsible for the overall clinical workflows. The TCM program is different from the annual wellness visit in that the provider must see the patient. And I would say that the provider needs to support that medication reconciliation, work with the patient to see which meds are you taking that we maybe don't need you to take, what questions do you have about any of your medications, and then maybe have an opportunity to reinstate any of those kind of pre-admission treatment type measures or any of those referrals. The patient was maybe going to therapy once a week on an outpatient basis. Let's make sure that we get the patient signed back up for that again. The biller and coder, I know it sounds like we're kind of picking on you, but we need to make sure that we're billing for that 99495, 99496 correctly every time. The administrator, one of your roles is going to be probably reaching out to some of those post-acute facilities, or maybe even working with your local hospital to make sure that you're getting your discharge notifications. Hospitals have an incentive to make sure that they're lowering their readmission rate. So any work that you can do to help them lower their readmission rate is going to go over well, and I think is going to make such a difference in terms of helping them to understand the importance of the ACO. And then the administrator and the manager, you're going to be in charge of making sure that the workflows, that not only are they clinically really sound from a provider overseeing them, but they make sense. That if we need to do kind of a plan, do, check, act, or plan, do, study, act, that we have a plan in place to quickly make some changes and modifications to ensure that we're able to get great outcomes. I mentioned when I talked about the billers that 99495, 99496, and those are the 2 codes associated with the transitional care management visit. The 99496 is the 7-day visit. So that's the visit within 7 calendar days, but there's also a couple other components to it. So it's the 7 calendar days, but it's a high medical complexity visit, and excuse me, and we're still doing that 2 business day interactive contact. So when I think about a high medical complexity decision making, I would say that it's probably comparable to how you would be documenting a 99215 in your notes today. Or if you're a provider that rounds in the hospital, maybe comparable to how you would document a 99233. The 14-day visit, the 99495, is going to be a moderate complexity decision making. Now you're still going to do that within 2 business day phone call, but this is going to be probably a little bit more comparable to maybe a 99214, or again, if you're the provider that may happen to round in the hospital, probably comparable to a 99232. So this is not saying that you need to do a 99215 visit in addition to a TCM program. This is just saying that the documentation for a 99496 is probably going to be comparable to a high-level office visit. And a TCM visit does not prevent you from seeing the patient for a subsequent follow-up visit. I've seen some practices that have had a lot of success where they'll bring a patient in, see them maybe on day 5, and then see them on day 20. And bring the patient in and see them on day 5 just to check on them, and once you kind of lay eyes on them, you go, you know what, I think we want to see you in a couple weeks just to make sure that you're going to be doing okay. And that second visit that they're doing, that's probably a 99214, and that's a separately billable visit. That is not considered part of a TCM bundle or a TCM service. That's a separate visit. And to help you be successful with this, and I know we had the wrench on a couple of the bottom of our pages, we have some Imperium Health toolkits and some resources that we're going to be providing to you. We're going to get ACO Health Solutions up for you, and that'll be a way to monitor your performance real time. And then myself and a couple other team members will be the Imperium Health team staff to make sure that we're giving you the support that you need. And the next steps for you as an organization would be to kind of go through these checklists. And I would say that for the annual wellness visit program, you're going to want to make sure that your EHR's template is in place, or if you don't have a template in place to build or for an annual wellness visit program, figure out what it would take to build it. And that may mean contacting your vendor. You're going to start to educate your staff about what is this annual wellness visit and what is my role within it. You're going to need to make sure that your billing and your coding is done as accurately as possible, and that also includes making sure that your EHR is able to bill for the full 12 codes as opposed to the 4 which sometimes we see. And that your scheduler is going to start proactively scheduling those annual wellness visits. And when I say proactively scheduling, usually that means reaching out to the patient to say, looks like you're going to come in 6 months. When you come in 6 months, we'd like to have you seen for a well visit. Is that okay with you? You're not going to have a co-payment? Great. Or if you're having a patient that's coming in that day, can we get them scheduled for an annual wellness visit? And then using some of the lists that we'll be able to provide to you through ACO Health Solutions to identify which patients have never had one before, or maybe not listed for a follow-up exam, that we can bring in and get them proactively scheduled for one of these visits. For the TCM program to be successful, one of the things we're going to want to make sure that you're doing right away is kind of doing a self-assessment of where are we getting our discharge notifications from today. Because if we're getting discharge notifications, great, now we're all ready to go to step 2. If we're not, then we need to kind of do that self-assessment of who do we need to be speaking with in the community about getting additional discharge notifications, or do we need to be coaching our patients to make sure that they're reaching back out to us right away to let us know that they were just discharged from the hospital. Then we're going to need to be educating our staff and educating our providers about the importance of these visits. We're going to start to establish those workflows to make sure that we're not only doing the phone call, but we're doing that face-to-face visit, and we have a good way of documenting for them. And then we're going to validate that our billing and our coding is accurate. So if we do those couple things for both of these visits, we're going to be really prepared to be successful, and you're going to be able to take that annual wellness visit and that transitional care management toolkit and do awesome things with it. And again, we're going to be here to support you every step of the way, but we like to give you the tools to be as successful as possible. So the next steps is, if you have not completed your practice profile, please try and get that done. That practice profile is really important for us to make sure that we're assigning the right patients within the ACO to the right providers. So look for an email from Mark from the Utah Medical Association for that. Start thinking about who within your practice would be the right person to maybe be a little bit more involved with the annual wellness visit or with the TCM programs. And that's it for now for those of you that are on the webinar. My contact info is here. Again, I'm Adam Kirking, and I work for Imperium Health, and this is the best way to reach me. If you have any questions or things that come up, please do not hesitate to send me an email, and I will be providing my cell phone number as well for you to contact me just about at any hour of the day. I definitely appreciate all of you being willing to spend a little bit of time with me today. I hope all of you have a great day, and I look forward to working with each one of you.